Shall I start, Hari?
Yeah, please.
Good evening, friends. A very warm welcome to the final session of this physician's course, in which we have heard from global experts and learned a lot of new things. I hope you all have enjoyed this program, and hopefully, this program has helped all of us to update our knowledge in the management of our heart failure patients. So, today, after the final session, there'll be an examination. Good luck to everybody, and over to you, Hari.
Thank you, Dr. Chopra. Welcome to the final day of the physician's course. We have, I hope we had 6 days of fruitful presentations and discussions. I think this time we had a very good number of around 400 people participated almost daily. And we will have the post test today. Post test, we will have 25 questions, and you can go through the test and take it and you have to have 75% of the scoring. Then the certificate will be automatically generated. If you are not able to score, you can take the test again any number of times. The basic idea is not to test, but to drive the messages which we have tried to convey through this physician's course. Basically, to improve the guideline-directed medical therapy in heart failure, which has shown to gain 7.5 years of life to a patient with heart failure. So that is a message, and that is why we are doing such courses to give the benefit of this therapy to patients with heart failure. So with that, today we have first the recap of the previous day's session by Dr. Sajan Ahmed. Then followed by our international faculty, Dr. Anna Abreu will talk on rehabilitation in heart failure, which is not very widely practiced in India. And then we will have a session by Dr. Tiny Nair on chronic heart failure, long-term management, how to follow up, when to stop, reduce drugs, etc. Very, very important topic. Then we will have a recap and a panel discussion with all those around. So you can post your questions, and based on the questions, we will have discussions. So please post your questions so that we can have a lively discussion. So over to Dr. Sajan Ahmed for the recap of the previous session.
Yes, I hope the slide is visible.
Not yet.
Visible, sir.
Yeah, visible, yeah.
Visible, right, sir?
Yeah, go to full screen.
Yeah.
Yeah, okay. Yeah.
Ready. So, good evening, everyone, and it's nice to be part of the HFAI program. And of course, the learning will continue today, and I hope the recap will be useful. And best of luck to everyone for taking the examination, if you can call it that. So, the last session we had a brilliant discussion on advanced heart failure current strategy of management by Dr. Frederick Verburg. Then we had an extensive discussion on cardiac transplantation by Dr. Sundar and a few interesting cases presented by Dr. Bhagirath and Dr. Sandeep Seth. So we'll have a quick glance at the key points. The first talk was on advanced heart failure, the current strategy of management by Dr. Frederick. And we all know about the progression of heart failure, and the important point that he stressed on was the concept of true heart failure remission, which includes 3 important components. One, restoration of systolic function, no residual congestion clinically, and no need for maintenance diuretic. So this would be an ideal situation of a heart failure remission. And as Harishnan sir has mentioned, the importance of guideline directed medical therapy is that when you use the drugs optimally, we gain up to 7 life years for our patients. And the important factor is that the sooner we start this treatment in the natural history of heart failure, the better will be the outcome. And the more complete your treatment, the better will be the outcome. An interesting concept of pulse pressure being utilized as a cheap man's Swan-Ganz was introduced. In fact, a case scenario was presented in which a a patient with a low systolic pressure of 90 and a diastolic pressure of 70 with a pulse pressure of 20 has in fact a mean arterial pressure of 77, but this patient has got a low cardiac output. And so the concept of using vasodilators in such settings was also discussed. The device therapy is underutilized, especially in India. And Dr. Frederick stressed on the fact that the early device therapy in indicated patients would actually enable more patients to receive the optimal doses of heart failure medications. And of the device therapies, the one with the maximum impact on improvement in the systolic function is, of course, the cardiac resynchronization therapy in patients with sinus rhythm, ejection fraction of less than 35%, and a QRS duration that is wide, ideally more than 150 milliseconds, and of a left bundle branch block morphology. And this is especially important that because patients with dyssynchrony cannot be cured completely with the use of drugs alone. And these patients should be actively searched for when we manage patients with heart failure. And regarding the CRT response, he stressed the fact that almost 50% of patients who are actually candidates for CRT do not receive the therapy, and this is a big global problem. And regarding the non-responders, in some particular situations, like in genetic cardiomyopathies, non-responder status, that terminology should not be applied loosely, because even a prevention of further deterioration of LV systolic function in such genetic cardiomyopathies could be taken at least as a partial response to CRT. Regarding ICDs, of course, to prevent sudden cardiac death, those who are candidates should be encouraged, and the incidence of sudden cardiac death is actually higher in countries which where the ICD adoption rates are low. Regarding slowing down of the disease progression, an extremely important component, because each decompensation leads to hospitalization and further impairs the outcome. And we have to take a more proactive approach to preventing heart failure hospitalization by intervening medically in the pre-symptomatic phase of the patient, and for which remote monitoring systems have been found to be very useful. Apart from that, what can be done practically in our situation is more dynamic diuretic treatment and up titration when required, but also down titration when the patient achieves a euvolemic status and is better decongested, so that the other medications can be given at the right doses, and also the incidence of dyselectrolytemia can be brought down by the judicious use of diuretics. Of course, in patients in whom the heart failure syndrome is contributed mainly by valvular disorders, like especially the secondary mitral regurgitation, intervention can be useful. And he concluded by mentioning that the ultimate goal should be heart failure remission with the use of the 4 pillars of therapy, and if possible, the use of pulmonary pressure monitoring to prevent congestion. Following this, there was a brief discussion, especially on the role of inotropes, and he mentioned that in his center and country, the use of inotropes have drastically come down, and they use it only when it is absolutely required. The role of levosimendan as an intermittent therapy was also discussed. Apart from, there was a question on the role of digoxin in patients with heart failure, and where he mentioned that he uses it mostly in setting of right ventricular failure or a biventricular dysfunction. After that, there was a talk on heart transplantation by Dr. T. Sundar, and he touched upon the latest International Society for Heart and Lung Transplantation guidelines in 2024, and also our own Heart Failure Association of India's 2025 guidelines on heart failure. The most important message that he gave at the onset was that transplantation should be viewed as a salvage procedure in a desperate situation, not just by the treating doctors, but also by the patient and the family, where everyone understands and agrees to the problems of immunosuppression in return for relief of symptoms, in addition to an increase in improvement in longevity. And he stressed on the importance of the heart failure team, and this I Need Help, which is an often quoted mnemonic for timely referral, where you identify patients who are potential candidates for transplant. And it doesn't mean that they all have to be referred for transplantation immediately, but we have to start the conversation with the patient and the family and list them for transplant. There are many heart failure models which are used to prognosticate, and heart transplant should be considered if 1 year survival is less than 80%. And cardiopulmonary exercise testing is extremely important for patient selection with a VO2 max of less than 10, a predicted survival of less than 80%, and a medium or high risk score. So if the VO2 max is more than 14, it may be prudent to defer listing. The crux of the issue is to identify the optimal transplant window where patients should not be too well and should not be too sick to undergo a transplant, and this is actually the challenge. Patients may require heart transplant due to multiple indications, due to varying etiologies of heart failure. And there are some absolute contraindications like a systemic illness with a reduced life expectancy, or an active malignancy, or HIV infection, or significant lung disease, or fixed pulmonary hypertension. There are other relative contraindications like severe peripheral vascular disease and symptomatic carotid stenosis which could be controlled with the use of various other therapies, and then these patients could become candidates again. Now, recently there has been a change in the approach to the transplant recipients. So the age, earlier it was 60, but now surgeons are accepting older patients. They're accepting more obese patients, even up to a BMI of 35, and cancer therapy has improved dramatically, so that many patients who had history of cancer may ultimately turn out to be recipients too. Regarding cardiac investigations, he stressed on the basic evaluation apart from the perfusion imaging and cardiac MRI, and to look for viable myocardium, which could be improved by revascularization. The most important part of the assessment is the assessment of the pulmonary vasculature, and PVR of less than 1.5 or at the max 2 would is considered to be okay. Anyway, a PVR of above 4 is considered to be a no-go area. Renal factors and hepatic factors have to be considered, and immune screening is part of the pre-transplant workup. And situation specific to India is, of course, the late presentation with heart failure and lack of awareness regarding the option of transplant, the lack of availability of donor organs, and of course, the need for more social education. Complications, of course, which were mentioned are infection, especially related to the immunosuppressive therapy, rejection, coronary artery vasculopathy, and the side effects of mandatory anti-rejection drugs, especially the increased incidence of cytomegalovirus infections and accelerated atherosclerosis. Post-op surveillance, of course, is required because doing a transplant is only half the job, and surveillance is important. Currently, the median survival is 12 years, 1 year survival is more than 90%, 5 year survival is 70%, 10 year survival is 50%, and 20 year survival is 20%. So that is the data. And he concluded by stating that cardiac transplantation remains the most successful treatment for patients with advanced heart failure, which is refractory to medical therapy. Then we had 2 excellent, interesting cases by Dr. Bhagirath Raghuraman. And so this was the first case of a 54-year-old lady with breathlessness, and she had an ejection fraction of 50%, mild hypokinesia of the infralateral segments, underwent a CT coronary angiogram, which showed LAD and RCA disease. The MRI showed late gadolinium enhancement and multifocal areas of mid-myocardial to subepicardial enhancement. And the final impression based on the T1 and T2 mapping and the MRI sequences, whether it is an acute myopericarditis, probably granulomatous or eosinophilic myocarditis, and a differential diagnosis of Churg-Strauss syndrome was also mentioned based on the blood parameters also. The patient had a hypermetabolic pattern of mediastinal lymph nodes on PET scan, and the patient underwent PCI to the LAD and RCA for the coronary artery disease. Endomyocardial biopsy was done for this patient, which revealed findings suggestive of eosinophilic myocarditis and subendocarditis. The eosinophil percentage was a whopping 43%, and patient had a troponin, significant troponin elevation. So the diagnosis of an eosinophilic myopericarditis with a hypereosinophilic syndrome was done, and steroids as a first-line therapy was done, and patient improved, this systolic function improved. The second case was again a 37-year-old male who presented with a large pericardial effusion in cardiac tamponade. So this was a large pericardial effusion, immediately drained. And subsequently, the patient underwent cardiac MRI, which showed features of non-ischemic dilated cardiomyopathy. And there were areas of transmural enhancement in the cardiac MRI. Endomyocardial biopsy was done, which showed diagnosis of, again, eosinophilic myocarditis. For this patient, had to undergo ECMO initially, followed by steroid, and then the patient LV function improved. So these two cases highlighted the eosinophilic myopericarditis in hypereosinophilic syndrome, which occurs with a persistent eosinophilia of more than 1,500 cells per microliter, evidence of end organ damage, cardiac, cutaneous, lung, GI, or nervous system. And cardiac involvement is seen in almost half of the patients with hypereosinophilic syndrome. The last session was on a case which was from Dr. Sandeep Seth and team, which was presented earlier at ESC 2025. A 15-year-old boy, asymptomatic till 12 years of age, presented with 3 years of history of dyspnea on exertion. The ECG interestingly showed a short PR interval with a delta wave pattern of pre-excitation, which was the clue. And the X-ray showed cardiomegaly. Patient had elevated liver enzymes, elevated NT-proBNP, and his CPK was elevated, and LDH was also elevated, and the myoglobin values were also elevated. Patient had significant left ventricular hypertrophy, mitral regurgitation. Cardiac MRI was done, and the diagnosis made was of LAMP2 deficiency or Danon disease. Then there was a discussion on the differential diagnosis in this setting, which should be the condition to be considered included Fabry's disease, Pompe's disease, and various forms of hypertrophic cardiomyopathy. So the major features of Danon syndrome were discussed. There is a disease expression which differs by sex. That is, the HCM-like presentation is seen more in males, and DCM-like presentation is seen more in females. There is cardiac involvement with pre-excitation, and there is also neurocognitive retinopathy, hepatomegaly, elevated liver enzymes, proximal muscle weakness, and psychiatric disorder. So this should ring the alarm bells. And the 2023 ESC guidelines were also discussed, where when you have a patient with a cardiomyopathy and a short PR interval or a pre-excitation, you have to think about glycogenosis, Danon disease, PRKAG2 cardiomyopathy, and Anderson-Fabry disease, apart from mitochondrial disorders. And if there is an extreme degree of left ventricular hypertrophy, we have to think of Danon disease, glycogenosis, and cardiomyopathy. And finally, it was the table showed that one important factor was among all these conditions, the elevated liver enzymes were seen only in the Danon cardiomyopathy, and genetic testing is now available, which can make the diagnosis. So with that, we will conclude. I hope all of you had a great learning experience over the last many sessions. But what is most important is, like what Hari sir said earlier, what we learn should be put forward into our practice, and the patients should get the benefit of treatment of guideline-directed medical therapy for heart failure. Thank you very much.
Thank you, Sarjan, for that wonderful summary of the last day's talk. I think you have done a wonderful job.
Yes,
So we will move to the next session by Dr. Anna Abreu on cardiac rehabilitation in heart failure. So that is a very important area. I think even though it has not shown significant mortality benefit, it improves the quality of life. So that is very, very important. The quality of life is very important whenever patient satisfaction is concerned. So over to Dr. Anna. Her talk is recorded. She will play. It will be played, and she will be joining the discussion at the end. Over to the recording.
Hello, I will be talking about cardiac rehabilitation in heart failure. My name is Anna Abreu. I am cardiologist in Lisbon, University of Lisbon, and run a program of cardiac rehabilitation. I'm also president of the European Association of Preventive Cardiology. So, as you know, heart failure progression takes us to the increase of exercise intolerance, dyspnea, fatigue, bad quality of life, psychological problems, higher hospitalizations and risk of death, and also weight gain and skeletal muscle wasting. So, European Society of Cardiology guidelines on heart failure management advise for heart failure patients to perform exercise to improve exercise capacity, quality of life, and reduce heart failure hospitalization, and also advises cardiac rehabilitation program for those who are with more severe disease, frail, or have comorbidities. In these guidelines, also from the European Society of Cardiology, from sports, it says not for only those who are with severe disease, but to all stable heart failure patients, we should perform cardiac rehabilitation programs exactly for that, to reduce hospitalization, to increase exercise tolerance, and to increase quality of life. And the meta-analysis also suggests that there might be a reduction in all-cause and heart failure-specific mortality. These recommendations are not only for patients with reduced ejection fraction, they are extended to patients with preserved ejection fraction, and they also improve functional capacity and quality of life in these patients. So for cardiac rehabilitation programs, we need a multidisciplinary team: cardiologist, an exercise expert, nurses, nutritionists, psychologists and psychiatrists, social worker and administrative, and all other specialties that we can gather inside this team. To achieve these components of cardiac rehabilitation, we will need all those professionals. We will have to do the patient assessment, the patient education, the prescription of exercise and the exercise training program, the risk factors and comorbidities management, the nutritional evaluation and intervention, specific counseling, psychosocial support, adherence to medication and monitorization, and then to have a cardiac rehabilitation report in the end for the cardiologist and do the follow-up of these patients. Starting by clinical initial assessment, of course, we need to know the etiology of heart failure, if the patient has devices or need for devices, to know the symptom severity and stability, to evaluate the cardiac risk factors and comorbidities, to know exactly what is the medication which the patient is taking and the adherence, to evaluate the contraindications to exercise, and to do a complete physical examination. If the patient has heart failure, but also has devices, cardiac devices like ICD or CRT, of course, we need to know the substract of arrhythmias, the indication for device implantation, and the intervention cut points. Also, besides the clinical direct evaluation, we need to evaluate exams, blood testing, the EKG, the echocardiogram, an exercise testing, and many times a 24 hours Holter monitoring. And if we can do the exercise testing with cardiopulmonary exercise testing, that will be better for heart failure patients. If not, it will be a standard or other functional tests. But with the exercise test, we can evaluate functional capacity, the existence of ischemia and arrhythmia, we can evaluate blood pressure and heart rate response to exercise, and we also can have prognostic indicators. So, before starting exercise, we need to make sure that the individuals with heart failure are clinically